Good afternoon, everyone. Center of Excellence at Gandhi Hospital, Telangana welcomes all the participants for today's RDLS session. Today's topic is aging with HIV, and the speaker is Dr. P. Sirisha. Dr. P. Sirisha, ma'am, is the associate professor with the Department of General Medicine at Gandhi Hospital, Telangana. We welcome you, ma'am, for today's session and request you to start the session.
Good afternoon, everybody. Thank you so much, ma'am. And moving over to our topic, uh, coming to the overview of today's meeting, the following points are covered. So, first, we will see about changing trends in the age of population, considerations before treating HIV in aging, and managing age-related non-HIV comorbidities like the following list, and a conclusion. And later, we can have the question and answer session after the completion of the topic. So, coming to the aging of HIV epidemic, insight from HIV estimation model at the NACP. Here we can see over a period of time, sorry.
Excuse me, ma'am. Ma'am, the audio is not very clear. Can you remove the headphones and try once? Disconnect the headphones.
Yeah. Coming to this slide regarding aging of HIV epidemic in India, we can observe here that over a period of years, the proportion of the people more than 40 years has been 50 years has been increasing. So this may be due to in general our population pyramid. We can see that in next few decades the age of the people greater than 50 years has been gradually increasing, and moreover incidence of new infections in HIV has been reduced. That is increasing the longevity of people, and the HIV availability of HIV for all is uh, increasing. So the proportion of people greater than 50 years are gradually increasing, as we can see in this slide. And coming to this slide, this is the comparison of overall, and this is a study from abroad, published in JAMA 2020. The comparison of overall and comorbid-free life expectancy between adults with and without HIV infection. Here we can see that the proportion of people without HIV infection is more, and also without HIV infection, comorbid-free life is also more. And here we can see the HIV bar AIDS in age greater than 50 years. The proportion of people growing old with HIV is 55%, and the people who are diagnosed late is 28%, and the new infection is 17%. The reasons for this diagnosed late 28% are low voluntary testing, and also the low suspicion, the low possibility of suspicion. So that when the suspicion is low, we are not able to screen them properly, and late presentation for diagnosis and care. And the cause for the new infection, which is attributed, is the newly single people, lack of awareness, no risk perception, and low condom use. This is a study done in Unison Medicare in 2018. And coming to next point, consideration before treating HIV in aging. So we can see here the changing patterns of the cause of death over a period of time in 2009 up to 2009. This was coming to the overall top 10 causes of the death. Here one can observe over this chart that the more number of deaths are due to non-communicable diseases like heart attack, stroke. And coming to the non-HIV comorbidities, one can see here that the patient with those who are HIV negative 65 plus years, the number of comorbidities have been gradually increased in both HIV negative and HIV positive. The significantly more hypertension, angina, MI, peripheral vascular disease, liver disease, CRF, and carcinoma in HIV positive patients. This was the cohort study of HIV and comorbid in Netherlands. Here we can see that age 65 plus years, the number of comorbidities has been gradually increased in HIV positive and HIV negative. And coming to this slide, so one can Give me 1 second. Yeah, coming to this slide, we can observe as the age is increasing, definitely the comorbidities will be increasing because the patient with less than 50 years, the number of comorbidities are less. And greater than 65 years, the comorbidities are more. When the comorbidities are more, the number of medications will also be increasing and there will be more drug-to-drug interactions. And for the patient, what are the points? Managing age-related non-HIV comorbidities. Increasing expenses with decreasing income, pill burden. As the more comorbidities are there will be more number of pills. Definitely the pill burden will be there for the patient. Increasing visit to the doctors and lab. So for the one condition, the patient has to go for one doctor, one cardiologist, one nephrologist, and for ART, he has to come to the ART medical officer. So the increasing visit to the doctors and labs. And because of the age, elderly people, there is a restricted mobility and increasing dependence. And here we can see ART definitely will decreases the event risk, but does not normalize it. And maybe because it is due to potentially blunted immunological response. Here we can see in the first year, the all-cause mortality and other cause non-AIDS death, non-AIDS infections, and compared to the after first year of starting ART, definitely the incidence of the mortality has been decreased. And the red dotted line, what we are seeing here is a standardized risk in the general population. So ART will definitely decrease the risk, but does not normalize the standard risk. So coming to the risk with aging in HIV, the patient factors, individual which are non-modifiable, their gender, genetics, hypogonadism, menopause, higher rate of traditional risk factors, which are modifiable risk factors, smoking, dyslipidemia, hypertension, diabetes, obesity, diet, physical inactivity, and poor engagement in care. And the poverty is one of the factors. And coming to the viruses, HIV infection itself will is risk factor, and inflammation and immune activation, co-infection, and late diagnosis of the infection. Coming to the treatment part, ART and toxicity and drug-to-drug interaction because of the polypharmacy. Moving to the next topic, diabetes mellitus. Coming to the glucose and insulin metabolism, the relative risk of diabetes in HIV infected is 1.2 to 2, and prevalence of impaired glucose tolerance is 18 to 35%, and in diabetes is approximately coming to 10%. And one more thing we need to observe from this graph is HbA1c underestimate the glycemia in HIV infected person. The target HbA1c will be a little bit different from the general population and HIV infected person. So HbA1c is it's not the target for the treatment for glycemia in HIV infected persons. Coming to diabetes screening and the management, how to screen the fasting glucose. If it is like 100 to 125, consider for the post meal blood glucose or postprandial blood glucose, or go for 75 grams oral glucose tolerance test. So when we should monitor the fasting blood glucose? In initial first time we should monitor at the initiation of the ART or after modifying at the time of modifying ART, and after that every 1 to 3 months, and fasting glucose should be done every 6 to 12 months in all the patients. Common drugs which are like there's an increased incidence of diabetes are lopinavir and some NRTs. And for the management of diabetes in HIV, definitely the individualization is the key. We can't follow the hard and fast rule for every patient. Based on individual status, we need to initiate the treatment. Goal for the prevention of the complications is HbA1c less than 7 to 8%. So in this chart, we can see that almost all drugs in ART medicines are safe, except from dolutegravir, where the metformin dose levels are increased. So we need to lower the dose of maximum dose of metformin in the patient with dolutegravir, because it increases the it causes a weight gain, which indirectly causes the metabolic syndrome. Moving to the next topic, cardiovascular disease. Changing CV risk burden. Because of the increased longevity of the HIV infected patient, there is increased increased prevalence of the cardiovascular disease. In HIV patients, there is a 1.5 to 2-fold increased risk of coronary artery disease and 4.5-fold increased risk of sudden cardiac deaths. And we can see here the relationship between the CVD risk in HIV and HIV treatment is U-shaped. After starting ART, definitely there's a rapid decrease in the CVD risk, but after starting ART, there's an increase over time driven by traditional risk factors, persistent inflammation, and drugs. So coming to this diagram, metabolic syndrome. The metabolic syndrome is the constellation of all these factors. There's a visceral obesity, low HDL cholesterol, insulin resistance, hypertension, and high triglycerides. So what is visceral obesity? What is the criteria to diagnose the metabolic syndrome? So at least 3 criteria should meet for the patient to be named as metabolic syndrome. So coming to visceral obesity, waist circumference 90 centimeters in men and 80 centimeters in women. Coming to the insulin resistance, the fasting glucose greater than 100 milligrams or being treated for the hyperglycemia. Hypertension, systolic greater than 140 and diastolic greater than 90 or being treated for the hypertension. High triglycerides, triglyceride greater than 150 milligrams or being treated for it. And low HDL cholesterol less than 40 in males and less than 50 in females. What is the step 1 in managing CV risk? Identifying those at risk. What are the cardiovascular disease risk factors? Hypertension, diabetes, dyslipidemia, obesity, physical inactivity, tobacco use, excessive alcohol consumption, unhealthy diet and nutrition, family history. Among these factors, some are modifiable, some are non-modifiable risk factors. So assessment. What is the risk assessment? Assessment shall be done at the time of registration of HIV care or ART initiation at 3 months, 6 months of ART and shall be repeated every 6 months thereafter. So at the start of initiation of the ART, we need to assess the CVD risk factors at 3 months and again after 6 months. So ask for the history of any past history of heart disease, stroke, diabetes or hypertension, any cardiovascular symptoms like angina, breathlessness, pedal edema, the facial puffiness, any passing of hematuria, any past present treatment, drug history should be asked for, current or past tobacco use and alcohol consumption, any addictions you should be asked for, and about the patient's lifestyle, whether he's physically active or sedentary lifestyle, any premature heart disease, stroke in first degree relatives. And assess. How do you assess this patient? When the risk factors are identified, we need to assess the patient. So how we assess? So BMI and waist circumference, measure the blood pressure, signs or symptoms of diabetes mellitus, examine for signs such as pitting type of pedal edema, any cardiovascular murmurs, any basal crepitations over lung examination, and abdominal tenderness like tender hepatomegaly, and lipid profile if available. So managing CV risk. Once you assess the history, identify the risk factors, how to manage a CV risk. So lifestyle modification is definitely required for all patients. And pharmacological therapy, we need to go for the lipid safe ART, lipid lowering therapy, management of metabolic syndrome and diabetes. Metformin will usually help in the weight loss and decreases insulin resistance. And consider avoiding abacavir in patients at elevated risk for the cardiovascular disease. So lifestyle modification management, we should be heart smart. So be more active. We should follow the ABC protocol. Avoid tobacco. Don't smoke. Smoking cigarettes greatly increases your risk for the heart disease. Eat healthy. Coming to B, ABC, avoid tobacco. B, more active, exercise. Get at least 150 minutes of exercise a week to lower your cholesterol and blood pressure. And eat healthy. Normal brisk walking is definitely very helpful because the elderly patient will having the osteoarthritis and so many bone problems. So normal regular walking is enough for them. And Surya Namaskaras based on their individual bone capacity and everything. And choose better nutrition. Eat healthy. Eat foods high in fiber and low in saturated fat, trans fat, salt, and cholesterol. So coming to this diagram, development of metabolic syndrome by intervention group in diabetes prevention program. Here we can see definitely the lifestyle has definitely decreases the risk of incidence of metabolic syndrome compared to the metformin and placebo. So avoid tobacco, be more active, choose better nutrition. Coming to the management, we need to replace with the lipid safe heart. So here we can see TDF and TAF regimens are more safe compared to abacavir, efavirenz, and protease inhibitors. But in protease inhibitors, we need to lower the dose of the statins. So, coming to the managing hyperlipidemia, match lipid treatment to the level of the risk. This is the criteria for the lower risk, moderate risk, high risk, and very high risk. So, treatment goals are for the low risk, non-HDL and LDL cholesterol should be less than LDL should be less than 130 and less than 100. In moderate risk patients, the targets are the same, less than 130 and less than 100. In also high risk, but in very high risk, the target values are a little bit lower side, less than 100 and less than 70. Consider drug therapy. Consider drug therapy in the lower risk for the non-HDL and LDL for greater than 190, 160. Same for the moderate risk patients, 160 and 130. High risk, non-HDL and LDL should be greater than 130 and 100. For the very high risk people, non-HDL and LDL greater than 100 and greater than 70. So here, as we discussed earlier, the protease inhibitor, definitely the dose of the statin should be definitely reduced, because as we give atorvastatin for 80 mg, we can't give 80 mg for those patients who are on protease inhibitor. So we need to consider lipid safe ART. So coming to the management, lipid lowering therapy, statin 44% reduction in CVD event, fibrates, fenofibrate considered when the triglycerides are greater than 400, omega-3 fatty acids with fibrates when triglycerides are greater than 500, niacin reserved after fibrates and omega-3 fatty acids, ezetimibe safe adjunct to statin therapy for modest LDL reduction, and also for those who are statin intolerant, ezetimibe can be used, and ezetimibe more specifically control the triglyceride levels. The dosing is 40 to 80 milligrams of atorvastatin and 10 to 20 milligrams of rosuvastatin. Simvastatin and lovastatin are contraindicated with the protease inhibitors. This is a ASCVD risk estimator scale. In this scale, we can calculate the risk profile. So we need to fill up all these details of age, sex, and race, and systolic blood pressure and diastolic total cholesterol. We'll get the risk estimator. This is the project risk reduction by the therapy. Coming to the BP for stage 2 hypertension, initiation of antihypertensive drug therapy with 2 agents of different classes in combination with the non-pharmacological therapy is recommended. For LDL, maximal tolerate statin recommended after clinician patient discussion. So for diabetes, smoking, and aspirin, lifestyle plays a very important role in prevention of these lifestyle disorders like diabetes and hypertension, metabolic syndrome, etc. Coming to the next topic, osteoporosis. So what are the dearrangements in a bone metabolism? In the patient, individual, gender, menopause, hypogonadism, high rate of traditional risk factors, smoking, alcohol, physical inactivity, malnutrition, vitamin D deficiency, hypothyroidism, and there is a decrease in the bone marrow density in elderly patient because of osteopenia leading to osteoporosis, which ultimately lead to fractures and avascular necrosis. Coming to the viruses, HIV infection itself, inflammation and immune activation, low CD4 and high viral loads, co-infections with HCV. And coming to the treatment part, treatment factors, ART and toxicity, and sometimes glucocorticoids. Here we can see there is a 6.4-fold increased risk of low BMD and 3.7-fold increased risk of osteoporosis. Here we can see that definitely the risk of fracture, incidence of fracture has gradually increased in women with HIV, and also definitely men, but women are more prone because of postmenopausal because for osteoporosis. So coming to prevalence in India, in ART naive patients, 61%, osteopenia 70.4%, and osteoporosis 29.6%. ART experienced 80.4%, in that osteopenia is 63.4% and osteoporosis 36.6%. Sorry, excuse me. So coming to this slide, the best tool for diagnosing osteoporosis is FRAX scoring system. There are online data FRAX tools. For greater than 40 or age, we need to assess the FRAX score. So if the FRAX score is less than 10%, in the next slide, I will show you how to assess the risk of osteoporosis based on FRAX score. So the low risk is less than 10%, moderate risk 10 to 20, and high greater than 20, or hip fracture risk greater than 3%. So we need to reassess the FRAX after 2 to 3 years. And for moderate risk patient, DEXA scan for BMD. And for high risk, we need to consider if the patient is in high risk for greater than 20%, we need to consider bisphosphonate without DEXA, though preferable. So if the patient is in moderate risk, the DEXA scan for BMD, the T score is greater than 2 minus 2.5, or if it's or with lowest risk less than 2.5, we need to consider bisphosphonate. So for these patients, we need to have adequate vitamin D and calcium supplementation, lifestyle modification, and workup for the cause of the secondary osteoporosis. DEXA monitoring on bisphosphonate therapy, repeat in 2 years. Initial T score minus 2 to minus 2.59. The to score 1 because already the patient will be on ART. So we need to enter secondary osteoporosis as S, and all other points should be filled up. We will get the BMD score. BMD score like this. The major osteoporotic 5.8, hip fracture 2.6. So coming to the management, lifestyle modification, exercise, smoking cessation, and alcohol reduction. Pharmacological therapy, vitamin D, 65 to 93% are deficient, and calcium supplementation. Safer for bones, heart, tenofovir to abacavir, TAF regimen, PI less impact on BMD as compared to TDF in treatment naive adults at the week 124. So here we can see the mean changes from the baseline. This is the lumbar spine and this is the hip. So there are greater improvements in BMD with zoledronic acid versus switch from the TDF. The zoledronic acid is given as 4 milligrams once in a year injection, or we can give alendronic acid. So here we can see the improvement in the lumbar spine BMD when compared to the zoledronic acid when they switch from the TDF. So coming to the differences between osteomalacia and osteoporosis in people with HIV, here we can see osteomalacia is due to deficiency of vitamin D. Osteoporosis is due to loss of the bone mass. So here the treatment is vitamin D supplementation, and treatment of the underlying cause usually reversible. But in osteoporosis, the treatment is bisphosphonate and it's not like usually reversible. So there will be mild to moderate vitamin D deficiency in osteoporosis. The treatment will be changing in both osteomalacia and osteoporosis. So coming to the dolutegravir with calcium and iron, DTG can be co-administered with calcium and iron supplement if taken with a meal. Under fasted condition, DTG should be given 2 hours prior or 6 hours after the supplementation, like antacids. Moving to the next point, next comorbidity, that is renal disease and hypertension. Individual predictors of new onset kidney disease in patient, that is BMI, smoking, hypertension, age, diabetes, and other factors are HIV infection, HIV associated nephropathy, and drug induced nephropathy. So here for screening, CKD screening, we need to go to do 2 tests, that is serum creatinine, proteinuria by urine dipstick test. So for the low risk population, we if we want to classify the patient with the low risk, so we should have this following point: EGFR greater than 10, urinary protein creatinine ratio less than 200, age less than 50. High risk, EGFR less than 70, UPCR greater than 500, age greater than 60, and associated hepatitis C, diabetes, uncontrolled hypertension, and CVD. For this patient, we need to avoid for low risk, standard ART can be given. For high risk, we need to avoid nephrotoxic ART like tenofovir, entecavir, and lopinavir. NRTS generally require dose adjustment, exception abacavir. Moving to the non-AIDS malignancies, cervical cancer screening. We should screen for the cervical cancer at ART initiation. Repeat screening within 3 years if the initial test is negative. Women who have been treated should receive follow-up screening at 1 year. Pap smear can be done. So coming to the breast cancer screening, clinical breast examination, all women living with HIV of age greater than 30 years at ART initiation we should do the clinical breast examination. Usually takes 5 minutes. That's so many videos on the YouTube how to perform the clinical breast examination. It takes about hardly around 5 minutes, but detailed examination should be done. And then again every 1 to 3 years thereafter. So these are the methods to be followed while breast examination clinically. This is a concentric circle approach. So we need to first visual inspection is important. First, we need to see any asymmetry of the breast. Again, we should go for the palpation method. That is the concentric circle approach, and it's a vertical linear method. So coming from up downwards, this is a radial scope method. Starting at 12 o'clock position, we need to do the examination, and again coming back to 12 o'clock position. This is called the radial scope or wish technique. And this is we need to examine for the 4 quadrants in each breast: upper outer, upper inner, and lower outer. In upper outer quadrant, when you're examining the upper outer quadrant, we need to examine the axilla also to for the as the breast tail of Spence issue will be there. And most usually some patients usually present with axillary lymphadenopathy. Retrospectively, the breast carcinoma will be detected. So screening for the oral cancer, this should be done for the both men and women. All HIV patients of age greater than 30 years should be screened using oral visual examination. It should be done for all patients, and regular visits for the tobacco chewers, at least annually for the others. Annually for the normal patient and regular visits for the tobacco chewers. So coming to the mental health, which is very much important, mental health and frailty are important for HIV positive patients. So mental health, HIV patients are twice as likely to have depression. Maybe that is due to stigma, rejection from the family, financial insecurity, dependence, fear of the disease and the death. Over 50 to 75% of the study group of older adults with HIV showed depression. It causes indirectly it causes non-adherence to all medications, including ARVs, and increasing the suicidal rates. So screening for the depression. Before initiating ART, thereafter every 6 months, use the following 2 questions. During the past 2 weeks, have you often been bothered by feeling down, depressed, or hopeless? During the past 2 weeks, have you often been bothered by little interest or pleasure in doing things? So immediately after the patient is diagnosed, the patient is newly diagnosed HIV positive, we need to counsel him. We need to give positive response to him, and having a good ear by listening to the patient is very much important. We should have empathy towards him. Then definitely the patient will come out of the depression. So how to manage the depression? Switch from efference, counseling, lending a sympathetic ear, teaching coping mechanism, stress management, ask him to keep him or herself very busy, to engage in other activities, other normal activities like whatever interest he or she has, social networks, and medication. So slow down, keep calm, be positive, take it easy, unplug, enjoy life, have fun, breathe, relax, go outside and meditate. Coming to the frailty, frailty is the 6th vital sign in the geriatric care. 3 out of 5 patients have unintentional weight loss. If self-reported, these are the frailty criteria. 3 out of 5 must be present. The unintentional weight loss, self-reported fatigue, low physical activity levels, weakness measured by the hand grip strength, and slow walking speed. Here we can see in HIV infected and HIV uninfected patient, unintentional weight loss, weakness, exhaustion, slowness, and the low physical activity is more in HIV infected patients. So how to manage? Usually the patient will have physical frailty, social frailty, emotional, metabolic, cognitive, and sensory. So use it or lose it. For physical, we need to do the regular exercise. Ask him for balancing exercise, flexibility training. And for social, we need to have self-help groups and social network. And nutritional interventions are very much important. Just not to advise that he should have good diet, but what to eat, at what time he has to eat, and what portion he has to eat. Also, we need to advise them. So we need to manage the frailty beyond the drugs, easy prescriptions, That is, the prescription should be very much simplified, and the nutrition part involving family, caregivers or support groups. Open-ended questions should be entertained. Uh, Mental health should be managed and avoiding multiple health visits. The comprehensive healthcare is very much important, as if there are more number of doctor visits, if there are more number of visits to the lab, the patient will coming to the doctor. So we need to have the comprehensive healthcare. So, helping the age with grace. Look beyond what you see. Widen our management focus. Strengthen screening strategies. One-stop shop as far as possible. While lifestyle changes remain the most important pillar, consider starting bisphosphonate when needed. Optimize the heart vaccination, but as of now, vaccination is not available in regular national program. And listen to them, have a sympathetic ear, and have empathy towards them. These are the online tools where we can see the HIV drug-drug interaction. You can take the screenshot of this. You can note it down the website. EGFR measurement, bone density frac score, as we have discussed earlier, and cardiovascular risk scoring and drug resistance. Thank you. ఎందుకు అందరూ తెలుగు కంపల్సరీ?
Thank you so much, ma'am. Any questions from the participants? Please feel
Is there any problem? You can ask me. I can communicate in Telugu also. The participants who want to have doubts in Telugu, I can communicate. Any doubts till now?
Any questions? Please feel free to unmute your mic. You can unmute your mic by pressing on the speaker icon. It is placed at the bottom of your screen on left hand side. Ma'am, I don't think there are any questions. Thank you so much for facilitating this session.
Okay, ma'am.
Yeah, thank you, ma'am. Thank you to all the participants for patient listening. We'll conclude the session.
Okay, thank you so much, sir.
Thank you, ma'am.